I would like to welcome you to today's webinar. My name is Ken Donahue, and I'm the Director of Communications and Member Services with Safe Care BC, the Health and Safety Association for BC's continuing care sector. It's a real pleasure for us to partner with medical pharmacies who will share their knowledge and expertise in this and 3 other education sessions over the coming year. Medical Pharmacies is the leading pharmacy services provider for continuing care communities in BC and elsewhere across Canada. And we are really pleased to have Gabriel Lee, a clinical consultant pharmacist with Medical Pharmacies, here with us today. I know that with COVID still present in our communities and as we move into cold and flu season, today's session is going to be particularly relevant for you. And now I'll hand it over to Gabriel.
All right, well, thank you, Ken, for the introduction. And thank you, Safe Care BC, for having me today. It's sure been a crazy year with COVID, and a lot of that has changed our regular rhythms of life. And one of the things it's forced us to do is to really fully embrace this digital platform. So it's a pleasure to be here with everybody today on Zoom as we discuss our topic today of sick day management, and in particular SADMANs. So just a little bit about myself. One of the things I usually like to do during the summer months is travel. And usually during the summer months, you can find me in some sort of a hot destination. These photos here are just a few places I've been to over the last few summers here. However, just like much of everybody else here today, there has been no traveling this year because of COVID and all the travel restrictions and travel bans in place. And that makes me a very sad man. But that's not really the SADMANs that we're going to be talking about today. Today we're going to be talking about a little bit of a different SADMAN. But given that summer has just come and gone, let's just hit pause there and imagine. Imagine we were able to travel, and imagine we were at a hot destination, and just close your eyes and just think about it. This photo here is very iconic in Nice. And just imagine yourself walking down the streets of Nice, or laying on the beach, reading your favorite book, listening to the waves come in, the blazing sun, in 30-plus-degree weather. And a lot of us may have been in those conditions before and started to feel symptoms like, having a dry mouth, or feeling very thirsty. You're suddenly feeling tired and lightheadedness. And those symptoms are symptoms of dehydration. Now think, those same symptoms of dehydration can happen in our residents when they get sick and dehydrated. And there are certain medications that can compromise their kidneys when they're in that kind of state. And that really brings us to our topic today of SADMANs. So to answer the question of, well, what is SADMANs? SADMANs is an acronym for a group of medications that should be held if a resident becomes dehydrated. And we know that SADMAN drugs can cause an increased risk of acute kidney injury, which we'll talk about later. And it also can cause an increased risk of side effects of the medications, as the kidneys aren't actually able to clear these drugs as efficiently due to reduced kidney function. And so there's reduced drug clearance by the kidneys in SADMANs. So given all of that, hopefully today we'll be able to answer 3 very important questions. And these 3 questions should be questions we always ask ourselves in terms of, any kind of medical issue. We should always ask ourselves, why is this important? Okay, number 1, why is this important? So why is this important to you? Why is this important to me? And most importantly, why is this important to our residents? Knowing why it's important, we also need to understand how it happens. Okay, so how does this all happen together? And once we have the why and the how, we're going to establish, well, what can we do about it? So to start off, I'd like to start off with a case example. And this is actually a real life case example. So it's not something that we just made up on the spot, or we typed in ideal situations. This is a real life example. And unfortunately, it's not an example that we're able to come to at the tail end of the presentation and talk about all the interventions we made. Okay, so I'm just going to read out the case example for everyone here. A resident in long-term care home had reduced appetite and fluid intake over 2 to 3 days. Due to her dementia, she was not able to communicate how she was feeling. The nursing staff continued to administer her SADMANs medication. In this case, it was an ACE inhibitor during this time. The resident was noted to have increasing lethargy, then was found unresponsive, prompting transfer to the hospital. Blood work at the hospital showed a serum creatinine of over 700 micromoles per liter, indicating acute kidney injury. After a couple days, the resident sadly passed away in the hospital. So we can see the impact of holding SADMANs medication from this case example. But to really understand acute kidney injury and holding SADMANs medications, we first have to understand the kidney. And so I have a kidney sprinkler analogy to share with everybody today. So just bear with me here as we kind of lay the groundwork of why holding SADMANs medications is so important. Okay, so think about our kidney as a sprinkler system, as you can see in this photo here. So a normal functioning sprinkler system, this is kind of how it would look like. You have your main pressure, the tap, the connector, the diameter of the hose, the inlet and the outlet for the filter, and then the sprinkler head. So a normal functioning sprinkler system would keep your lawn and your flower beds looking healthy and happy, just like you see in this picture. Now, think of that sprinkler head again there, okay? So think of that as the glomerulus, okay? Which is the part of the kidney that's actually responsible for filtering excess fluid and waste products out of the blood. And it's kind of what we call our GFR, or the filtration rate, okay? Now think of all the scenarios that could go wrong here, okay? Looking at number one here, having low pressure of water coming in to the sprinkler system would lead to less water flowing through the sprinkler, okay? So that's one thing that could go wrong. Another thing that could go wrong, if the tap is too tight, if the connector is too tight, that would also restrict the amount of fluid or the amount of water that is coming through the sprinkler system. And you can see there, if that hose coming up to that sprinkler head, if that hose is very tight and very narrow, that would also cause an increased pressure of water through that sprinkler system, and ultimately damage that sprinkler head. And if we go from the other side, and we block that hose at the end of the sprinkler, that would also increase the pressure as well to the sprinkler head and potentially hurt it as well. So in the same way, and by the same token, medications and our fluid status in our body can affect our kidneys, okay? So in that same way. So without getting into too much detail here, you can see that, focus in on the same parts here again. Number one, being dehydrated can put us into a hypovolemic state and really hurt the kidneys. If you look at that top part there where the tap is, if you think about that with diuretics, okay? So diuretics can also lead to volume depletion. So if you're already dehydrated and you're taking a diuretic, you're gonna further deplete your volume, okay? So further volume depletion with diuretics. You see NSAIDs there, okay? NSAIDs is our anti-inflammatory. They can work on that hose and cause it to narrow or constrict, okay? We call it constricting the afferent arteriole. So just think about it as like it's constricting that hose, which would increase that pressure to that filter head. And then there's your ACE inhibitors and your ARBs, which we're going to talk about a little bit later, and they work on what we call the efferent arteriole, or the hose after that sprinkler head there, or the glomerulus there, and it can affect it as well. So don't get me wrong, I mean, these are medications we see all the time: diuretics, anti-inflammatory, blood pressure medications like your ACE inhibitors. So under normal circumstances, we see these medications used very often. However, it's when a person becomes sick and dehydrated that suddenly their clinical status can change quite drastically. And in that kind of setting, the risk for acute kidney injury suddenly becomes very real and very possible. In fact, in the UK, AKI is associated with 1 in 5 emergency hospital admissions. So if you think about that, if you're sitting in the emergency hospital room in the UK, and you look in front of you, you look behind you, you look to your left, you look to your right, statistically speaking, one of those people is admitted into that hospital because of AKI, okay? And so where it hits home for us is that 2/3 of those AKI admissions are actually developed in the community, okay? So at this point you might ask, well why is that important? It's important because we know that AKI has led to and leads to poorer health outcomes. You often see people in nursing homes, or you might hear people having chronic kidney disease. Well, people are actually more likely to have chronic kidney disease, or what we call CKD, after an episode of AKI, okay? And so AKI is more likely to happen when the kidneys are susceptible to damage. And in our population group, they are like the perfect storm for that. So if you think about it, an example of older population with complex comorbidities and multiple medications, that population group is more likely to have their kidneys susceptible to damage. Now, statistics in hospitals have shown that AKI mortality rate is between 20 to 25%. And in critically ill patients requiring dialysis, that mortality rate actually shoots up to over 50%. So kind of going back to that case example that we talked about earlier, it's no wonder that that patient who was admitted into the hospital, her chances of survival were not very great, because we know that AKI mortality is a very real thing. So that kind of leads us to the crux of our presentation today, and that's sick day management. Okay, so just to reiterate, so when our residents get sick and they're unable to eat and drink sufficiently, they're suddenly at a risk of dehydration. And we know that dehydration, based on that analogy that we've had, is very stressful on the kidneys. Okay, so just to kind of remind everybody of some signs and symptoms of dehydration, we're talking about things like thirst, unusual tiredness, dry mouth, headache, lightheadedness, dry and cool skin, irritability, confusion, decreased urine output. And on top of this, certain medications can exacerbate this. And that's why these certain medications should be held when a resident is sick. Okay, so that kind of covers why that we're talking about this today. Now we're going to zoom in and focus on the how. Okay, so how do these group of medications actually affect the kidney when a resident becomes sick and dehydrated? So over the next few slides, we're just going to hit these one by one here, and that's really the SADMANs acronym that we're going to be talking about right now. Okay, so the first one, S, for sulfonylureas. So sulfonylureas are medications that are generally used to treat diabetes. And how these drugs work is they stimulate insulin release from the pancreas. Common examples of these are glycoside, glimepiride, glyburide. And in our care settings, probably you'll see the most common ones you'll see would be glyburide and glycoside. Okay, so the reason why we want to hold these medications is that when somebody is dehydrated, we're going to have reduced clearance by the kidneys. And that, as we talked about earlier, will increase risk of side effects. And the side effects that we're worried about in this case is hypoglycemia. And we know that hypoglycemia can have a lot of negative health outcomes or a lot of health complications because of hypoglycemia. And so we definitely want to avoid that. The next one is our ACE inhibitors. So A for ACE inhibitors. Okay, so ACE standing for angiotensin converting enzyme. And so how these drugs work is what they do is they inhibit an enzyme to help lower our blood pressure. And so some examples of these, you'll see probably the most common ones being used are your ramiprils, your perindopril, enalapril. So all these kind of meds ending in pril, a lot of these are ACE inhibitors. And it's a class of medications that we love to use. And we see a lot of our residents on these medications, and for good reason. They have really strong evidence supporting its benefit in medical conditions like hypertension and heart failure. And you may have actually heard of these medications used with, in people with diabetes or chronic kidney disease as what we call a kidney protector. They're on board to help protect the kidneys. And so it can become confusing as to why we want to hold these medications if they're there to protect the kidneys. So the answer to that is twofold. For one, these drugs should be held because they can lead to hypotension, which is a lower blood pressure when the resident is also dehydrated, right? So if they're dehydrated, we might cause a more exaggerated decrease in their blood pressure. And the second part of that is we gotta think back to our sprinkler analogy again. We know that what these drugs do is they work on the hose that's after the sprinkler head, right? So they work to inhibit the vasoconstriction of that hose or that efferent arteriole, which means it causes it to dilate. Now, normally that's a good thing, but in times of reduced renal perfusion, that could cause a fall in the GFR, and that could cause more damage to the kidneys. So if you're somebody who needs that, who's a visual learner, think about this as our hose, right? So the afferent and the efferent arteriole, and then glomerulus being that sprinkler head. Okay, so what the ACE inhibitors normally do is they will dilate that efferent arteriole. But let's say a resident right now is sick and dehydrated. We already know that they already have reduced renal perfusion to their kidneys. So by dilating that efferent arteriole, what we actually end up doing is we decrease that perfusion even more and can cause kidney damage, which is our acute kidney injury. Okay. Now moving on to D, D for diuretics and our direct renin inhibitors. So diuretics and direct renin inhibitors are used to treat lower blood pressure, are used to lower blood pressure, increase urine output, or what we call diuresis, and reduce fluid in the body. Lupin thiazide diuretics. Okay, so there's different classes of diuretics. We're just gonna go through a few of them here. So there's the lupin thiazide diuretics, and what they do is they lower blood pressure by inhibiting the reabsorption of sodium and chloride. Okay, we also have our aldosterone antagonists, and what they do is they lower blood pressure by inhibiting aldosterone to prevent potassium excretion and sodium reabsorption. So those are your diuretics like your spironolactones. And then there's the direct renin inhibitors, which lower your blood pressure by inhibiting renin to promote the excretion of sodium and water. And so common examples of these, your loop and your thiazide diuretics would be like your furosemides, your hydrochlorothiazides, your chlorthalidones, okay? And so if we think about these drugs can worsen dehydration due to their diuretic effects. And that's how it can increase the risk of acute kidney injury. So when somebody is dehydrated, the last thing we want to do is cause more volume depletion by giving them a diuretic. Okay, so that's why we really want to hold these medications when somebody is dehydrated and sick. Now we're moving on to M, M for metformin. Okay, so metformin is a drug we all know, it's such a common drug. And so this drug is used to treat diabetes. And how it works is it works by decreasing glucose production in the liver, and improving sensitivity to insulin. Okay, and so metformin can come as is, by just metformin, or it can come in combination products. So you have to watch out for those as well. So some common ones we see here, metformin and sitagliptin, or are also known as Janumet, metformin and linagliptin, known as Gentadueto. Those are probably the more common ones that we see in our practice. And so metformin can come just as it is, or in a combination product. And so coming back to the reason of why we want, or why we need to hold these medications, and this is similar to the sulfonylureas that we talked about in the beginning, is we want to hold these due to its reduced clearance by the kidneys when somebody is dehydrated, because of increased risk of adverse effects. Okay, and the main one adverse effects that we're worried about with metformin is lactic acidosis. Okay, and you might be thinking, well, lactic acidosis is such a rare side effect. Why should we even be concerned? Studies have actually shown that most of the cases of lactic acidosis were described in association with an AKI episode derived from hypovolemia. So under those conditions, right? Under those conditions where somebody is dehydrated, they're hypovolemic, and they have, or leading to an AKI episode, they're at a much higher risk of having side effects of metformin that we normally probably don't see very often of lactic acidosis. And that's why we should be concerned and hold metformin while somebody is sick and dehydrated. Now, the second A of SADMANs is what we call our ARBs. And so ARBs kind of standing for angiotensin II receptor blockers. And these medications are kind of a class of medications we can almost say are a cousin to our ACE inhibitors. They work very similarly, and most often people are on an ARB is because they cannot tolerate an ACE. So one of the side effects of an ACE inhibitor is this dry hacking cough that is very irritant for a lot of people. And so they might switch over to an ARB, which doesn't have that side effect and still has the full benefits of blood pressure lowering. So what they do is they lower the blood pressure by inhibiting effects of hormones that causes the blood vessels to enlarge. And so there's been a lot of media attention on these in the last year. You may have heard of some of them in the news, your valsartans, your losartans, irbesartans, candesartan, telmisartan. So a lot of these drugs all ending in sartans, great drugs that we use for treating high blood pressure, heart failure. Those are just several of the conditions that these medications are used for. And so the reason why we want to hold these medications is for the same reasons why we would want to hold an ACE inhibitors, okay? So just think of these two groups of medications as cousins to each other. So the reason why we hold an ACE is the same reason why we would hold an ARB when we're worried about acute kidney injury. Now moving on to N, N for NSAIDs or NCOXIBs. So NSAIDs standing for our non-steroidal anti-inflammatory drugs. Okay, so these are medications we're using to treat for pain control and inflammation. And how these drugs work is they inhibit an enzyme to decrease the production of compounds that mediate the sensation of pain. And that's kind of how they work as a painkiller. And so the examples of these would be, the common ones that we might see in our practice is your naproxens, your diclofenacs, your ibuprofens, your aspirins, and maybe even indomethacin for gout. So in our older population group, We typically don't see too much of these medications, but sometimes we do see them used here and there. And so when somebody is dehydrated and then their fluid status changes, it's really important to hold these medications as well. Now, if you think back to our sprinkler analogy again, so referring back to that analogy again, we know that NSAIDs will actually work on the hose that leads up to the sprinkler head, okay? And so what it does is it inhibits the vasodilation of that, so meaning it causes vasoconstriction of the hose or the afferent arteriole, and that's how it can increase the pressure going into that glomerulus and causing a fall in the GFR. And that's why these medications should be held when somebody is dehydrated and their fluid status does change. It is, however, important to note that somebody who's on a baby aspirin, so we're talking about 80 milligrams or 81 milligrams of aspirin, that can be kept going. So those don't have to be held, so that's exempt when a resident is sick or dehydrated. Whereas we're talking about our full dose aspirin, so your aspirin 325 milligrams, typically your over-the-counter painkiller aspirin strength, those would be considered a full dose and should be held in these situations. So again, for people who are more visual learners, going back to that same diagram, if we look at this with the glomerulus in the middle, okay, your afferent arteriole, or that hose that leads up to the sprinkler, what happens with NSAIDs is that it causes that constriction, right? And we know the outcome of this will be decreased renal perfusion as well, and that can damage the kidneys and cause that acute kidney injury. So to finish off with the last S of SADMANs, this is a relatively new class of drugs. They're called our SGL2 inhibitors, and these drugs are generally used to treat diabetes. We probably don't see it too much in our population group because they are relatively new, meaning that they're usually not covered. So unless somebody has a great private plan, it usually costs quite a bit and they're not covered. And they're not favored too much in our older population group as well. So we don't see them as often. There can be cases where you might see these medications. And so basically how these medications work is they work by lowering blood sugar levels by inhibiting glucose reabsorption in the kidneys. And common examples of these would be your canagliflozins, dapagliflozins, empagliflozins. So all these medications ending in gliflozins, we probably know them by their trade names right now because they are still relatively new. So things like Invokana or Jardiance are probably the more common ones that we see here. And so the reason why they should be held is, under conditions that can lead to dehydration, there is actually a risk of developing something that we call euglycemic DKA, so euglycemic diabetic ketoacidosis, which is a very serious medical emergency. It is quite rare. It doesn't happen very often, but it can happen, especially under these circumstances. So there has been an established association, though it isn't as common, of DKA with normal glucose values. And that's why, under these circumstances, we do want to hold these medications for risk of acute kidney injury and risk of euglycemic DKA. So that really covers the why and the how, okay? So now that we understand why it's important and how it all happens in the body, for the tail end of this presentation, we're gonna focus on the what, okay? So what being what we can do about this, okay? So we've identified a very simple 3-step process that can safely hold these medications when a resident is sick and dehydrated, okay? The first step being we want to identify, okay? We want to identify and assess residents who are at risk, okay? Seeing who is actually at risk of dehydration. Number two, we want to hold these SADMANs medications while they are, acutely ill or dehydrated. And number three, we want to reassess and restart these SADMANs medications when it is safe to do so. So it's not that these SADMANs medications are necessarily toxic to the kidney, okay? We're not saying that they're toxic to the kidney. It's under the circumstances that somebody is dehydrated and sick that we want to hold these medications until they recover, okay? So starting with number one, identifying and assessing. I just want to throw another acronym at you today, okay? So another acronym of fluids, right? So when we're identifying, the first step we want to do is think clinical, with our clinical hat, think fluids, okay? So F for fluids, is the resident having trouble drinking normally, okay? We're gonna look, okay? Look, do they look ill? Do they feel ill, okay? We're also gonna look at their urine, okay? Are they passing much less urine than normal? What does their urine look like? Is it dark and concentrated? I for infection, we're gonna consider, does the resident have an infection right now? Are they running a fever? And D, which is what we really focus on today in this presentation, is what drugs are they on? Are the drugs gonna affect their fluid status, or is it gonna cause more complication to their kidneys? And for those of you who are with medical pharmacies, we do have a sick day medication report that gets generated on a monthly basis. So the nice thing about this sick day medication report is that it will highlight all the residents who are on SADMANs medications. And so you can just print this report off on a monthly basis or refer to it on our resource center on a monthly basis. And when you have a resident that falls sick and their fluid status does change and they are dehydrated, you can cross-reference to this list and see, are they on a medication that could compromise their kidneys even more? Okay, so number two, holding SADMANs medications. This is the step where to contact the MRP, the prescriber, to evaluate and assess and potentially hold these SADMANs medications for the duration while a resident is sick and dehydrated. And so here is just an example of a sick day order form that is available with medical pharmacies. And so it's a very simple form, one-page form that has the instructions. It has the SADMANs, as you can see down the side there, and goes through the common SADMANs medications. And so, if a prescriber were to hold them, it would just be as easy as checking off the medications that resident is taking and to hold it. And it does have all the legal requirements, as you can see on the bottom, for a prescription as well. So it has all the drugs listed, it has the legal requirements for it, and it's a nice simple one-pager. So a sick day order form for these circumstances. And number three, to reassess and restart. Okay, so this is where this is the ongoing monitoring part, right? Where you reassess and monitor that resident daily. You're going to document any status changes in the progress notes. So you're going to be looking at signs and symptoms. You might start using some daily tracking tools to check their fluid intake, their infection status, if that's applicable. And then when the resident's condition starts to improve, you want to contact the prescriber for a telephone order to restart the held medications. And note that that when the prescriber restarts the medications, they might actually restart it at a lower dose. Okay, so if that's the case, all you have to do is just transcribe those new orders and process as per the usual procedure. If you are with medical pharmacies, you'll know that you could just use the digital pen and the digital paper to do that, and simply by docking the pen, that information will get passed on to the pharmacy. And just to summarize it all for everyone today, we know that residents who are at risk of dehydration when they become sick and are unable to eat and drink well. And we know that if those residents who are dehydrated are taking SADMANs medications, it can lead to very serious adverse outcomes the main one that we've been concerned about is the acute kidney injury. But we also know that the kidney is responsible for filtering drugs. And so levels of drugs can increase because of that. And so we're worried about drug side effects, like we talked about with the sulfonylureas and hypoglycemia or metformin and lactic acidosis. And in the worst case scenario, it can even lead to death, which is what we saw in our case example, which ended up actually being a real life case example. So it is very important to hold these medications. And so if we can just follow this 3-step process or procedure, that can really help to benefit our residents, especially now as we're entering our flu season, coupled with this pandemic and COVID. We want to make sure that when our residents get sick, which some of them probably will in the flu season, and that's almost inevitable, that when they're sick, we are monitoring their fluid status. We are monitoring if they're dehydrated, and we take the appropriate measures to prevent things like acute kidney injury as much as we can. By preventing acute kidney injury, you're not only helping the residents, you also might save them an admission to the hospital, right? We know that, like from our neighbors in the UK, that 1 in 5 hospital admissions are associated with acute kidney injury. And so during the times of a pandemic with COVID, we want to avoid hospital admissions as much as we can as well. And so it's very important that we do consider these SADMANs medications. Now, if you are with medical pharmacies or aware of medical pharmacies, we do have drug news and resources and newsletters that we do send out. And you'll see that the edition in July has actually gone through SADMAN. So you might have already heard of this before or read about it before. And so you can see that on the pharmacy QI, there's the acronym SADMANs there, and just a nice flow chart of what to do in different situations when a resident is sick. Also with our drug news of sick day management, it goes into a little bit more detail of examples of these medications and the reason why we want to hold them, all in a nice newsletter. And so we actually have quite a lot of resources and newsletters that get updated on a regular basis. So if you are interested or any of that does interest you, all of our newsletters can be found online. And for any more information about medical pharmacies, that all can actually be found online at www.medicalpharmacies.com. And if you're looking directly for those newsletters, just hit /resources behind that URL. And if you do have any questions about medical pharmacies at all, feel free to reach out to us. You can reach out to us at sales@medicalpharmacies.com. All right, thank you, everybody.
Gabriel, thank you very much. It was very insightful, and I think you've raised a very important topic. I think I took from it the story that you shared at the beginning about the resident and how there are certain things that we can do in practice to make sure that people stay healthy and safe. And I know that your message today will go a long way in helping that. So definitely appreciate that.
Thank you.
I want to open it up to questions. So obviously lots of information packed in there from Gabriel. So if people have some questions, feel free to send them through to the chat function. And Gabriel, we have one question here that was sent to me. And the question is, what happens if sickness lasts a long time? Do you continue to hold indefinitely?
It'll depend. So we want to monitor their fluid status, right? And so if they're sick and they aren't dehydrated, then we can probably resume the medications. And so what physicians or the prescribers might do is they'll probably monitor the serum creatinine. Okay, and so we know with serum creatinines and the GFR, as we get older, our kidney functions will start to decline, but there usually is a baseline that all of our seniors or our elderly population will be at. And so if their GFR is just trending at their baseline, then these medications are probably safe to restart. If their serum creatinine shoots up and you know, it's percentage point wise is still much higher than what it's usually at, or their GFR is much lower than what it's usually at, it probably is safer to hold some of these medications. And I didn't get into too much detail about that because with these medications, it's going to be a case-by-case basis. So if you pull metformin, for example, if their GFR is consistently below 30, we're not going to even bother restarting it because the risk of side effects would just be too high, and it isn't recommended to have metformin when somebody's GFR is below 30. And so it would become a case-by-case basis at that point. And so that's how we would have to approach it.
That's great. Thanks, Gabriel. Is there anybody else who have any questions? Are there questions? We have some shy people out there. If there are no questions, so as what we promised that we would share the recording afterward, we'll share Gabriel's notes with everybody. And again, if there are no more questions, Gabriel, thank you for your presentation. It's insightful. It's important information to share with the continuing care community. So we appreciate your time. We want to thank again Medical Pharmacies for sharing their expertise, their knowledge with us. And we have some more webinars with Medical Pharmacies coming up. We don't have any set dates yet, but they'll be coming, so stay tuned. And we'll be sure to share that information with you. So thank you again, Gabriel. Thank you, Medical Pharmacies. And enjoy the rest of your day, everybody.
All right. Thanks for having me.